I'm really honored to be here today. And as he said, I'm a laboratory genetic counselor at Mayo Clinic. I work closely with Dr. Matern. Prior to that, I was a clinical genetic counselor at Children's Hospital of Wisconsin for 12 years. And I've worked with the Wisconsin Newborn Screen Program for almost 25 years now, and Minnesota for about 10. So hopefully that gives you a little bit of background. This idea of looking at these outcome data for patients with 4 GALC variants came from a discussion that I had with Dr. Saavedra Matiz, or Carlos, in the newborn screen program in New York State. We talked about how there were several variants that showed up repeatedly in these patients, but we knew that the majority of those patients did not appear to have symptomatic Krabbe disease. And so we've heard feedback that a lot of the state newborn screen programs have concerns, of course, about false positives, and we need to learn more about these so we can try to figure out who's really at risk or not, as others have already mentioned. So Carlos provided this data that they noted the percentage of carriers or homozygous compound heterozygotes for the following variants were made up a significant percentage of the babies that they found with abnormal newborn screens. And so we'll talk about those today. The first two, M117V and L634S, made up about 4% of the positives, but the ones that really concerned us more were the Y319C and T112A variants. And of course, when we look at variants, it's not in a vacuum or alone, but as part of an entire genotype. So we're trying to figure out what these patients look like, if they're homozygous or compound heterozygous. So our hypothesis was that because we've heard about so many of these infants who are asymptomatic for so long, are any of the variant classifications incorrect that are currently assigned to these variants? And if we are able to have better outcomes data, can we then reclassify any of them? So the goals were to analyze the biochemical results from these patients and clinical outcomes for those who have one of these 4 GALC variants to determine if the classification is correct. And these are the current variant classifications. So the first two really do appear to be pathogenic, but again, we've heard through word of mouth and phone calls that I make on results from our lab that some doubted they were actually pathogenic because their patients were asymptomatic for a long time, or they heard they were very late onset. The latter two variants, Y319C and T112A, really had more question regarding whether or not they were pathogenic. So for this study, we decided to collect data from multiple clinical laboratories and also clinical specialty sites who have long-term experience with these patients. And so we are still in the process of this, but we have clinical sites that have worked with us and provided data from 4 states. There are also individual patient cases where we've obtained consent in states that don't do newborn screening, but have identified patients with these variants. And then we're still working with 3 other states to get some information. And so it's a work in progress, but I am showing you what we have so far. The thought of combining the data is that New York has the longest newborn screen history, but then we also receive testing in the Mayo lab from patients who are symptomatic at all ages. So we have adults who have had biochem testing nationally and internationally, and we think that might be informative. And for the biochemical data collection, we really looked at the enzyme and biomarkers like cytosine. We do have some limited data that I won't present today on like CSF protein and some other things, but really we're focusing on those 2. And then our clinical data collection comes from a follow-up survey that's used by New York State Newborn Screen Program. We just added some questions with the assistance of Dr. Rajan about neurology outcomes, so clinic visits, brain MRI results, etc. And here is the money slide. So here we have what outcomes show. The numbers are higher from our biochem lab at Mayo because I've included the carrier data. I don't have the carrier numbers yet for New York State, but we have all of those that have genotypes of concern. And so when we look at this, we see that there are quite a number of babies identified, but then if you look at the far right, you'll see that not many are symptomatic or have developed disease yet. And let's take a deep dive into each one of these. So if we look at the M117V, we see that there has been an adult Krabbe disease confirmed case, and that patient is compound het with the R396W variant. And then we have SIBs reported from a non-newborn screen state who are compound het with this variant you see here, who had pretty elevated cytosine levels at 14 months, and then the younger sibling at 2 months, respectively, and really appeared to have infantile Krabbe disease and were transplanted. So here's a snapshot from Franklin because it's a nice visual image, but if we actually look through all of the ACMG 2015 criteria, it really does seem that the M117V GALC should be classified as a pathogenic variant. It's been reported in multiple individuals with Krabbe disease, infantile and late onset, and so we don't really think there's a lot of question about that classification. If we move on to the L634S variant, we've heard of this one. It's more common in some subpopulations, but of the patients that were identified, all of the homozygous patients had normal cytosine, but the compound heterozygous patients, we had 5 with elevated cytosine. And the very last one there had an elevation of 15 and infantile Krabbe disease. And that infant was also born in a non-newborn screen state. And so this is helpful for us because this is a case actually where I had to convince the providers that the baby actually had Krabbe disease. They said they read L634 as was late onset. Is this really it? Let's repeat the cytosine again, which we did. But there were lots of conversations about whether or not this was real. And for those of you who see these numbers, you know that it is. So sometimes when the literature says late onset variant or that L634S is causes adult onset Krabbe disease when it's homozygous. People don't think about it causing disease in the compound heterozygous state in infants, but it can. So similar to the M117V, the L634S variant classification of pathogenic does seem to be accurate as well. And if I'm flying through this, it's because I have a short time. So I want to get to the good stuff. Okay, so Y319C, many of you have encountered a number of patients with this variant. And we have 12 homozygous patients who had elevated cytosine with Y319C, but only one that was elevated and became symptomatic. And this is a pretty important case from New York State that is, hopefully there's a publication that's supposed to be in process right now, which is good. I've talked about this case a number of times, but the patient's homozygous for Y319C and the pseudodeficiency allele I562T, which is the most problematic, we think, in that it actually does reduce GALC activity the most of all of the pseudodeficiency or polymorphic alleles, and also D248N. But then of the compound heterozygous patients, we also see that there are 4 that developed infantile or late infantile Krabbe disease. And their additional variants are listed there as well. The one where the dried blood spot and red blood cell are known is because that baby is a child and so old that it predated cytosine. So we have some old data. So the Y319C GALC variant classification shows a lot of conflicting calls, likely pathogenic, VUS. I've seen multiple different calls from different genetic testing laboratories, which is confusing for the clinicians who get these reports back. But it has been reported now in patients with homozygous Y319C and with later onset Krabbe disease. It's not yet been reported in patients with infantile Krabbe disease. So pathogenicity isn't age of onset dependent. If it causes disease at any age, we call it pathogenic. So this does seem to be a pathogenic variant. I think that classification will move from VUS or likely pathogenic to pathogenic once this new case is reported as well. But finally, I think our biggest take-home message looking at this was analyzing the T112A variant and clinical outcomes in infants who have this, because it really accounted for the largest number of infants who screen positive. And as you can see here, the vast majority have normal cytosine. And then of the 4 that had elevated cytosine, it was just above the cutoff of 2. And we're still getting outcomes data from these, but we don't know of any patients who are symptomatic with T112A who are children so far. So this is where we might be able to make a difference in reducing false positives from that 2 to 10 range of cytosine, is with this variant. And if we can reclassify it. Okay. So T112A is considered a VUS, or a variant of uncertain significance. It is highly conserved, and metapredictors suggest that this amino acid change may impact protein function. When we look at the minor allele frequency, though, it's a little bit more than, and makes us question whether or not this might actually cause disease. But what do we know about individuals with this variant from the literature? Because there is a number of papers that include this variant. This case by Nashabat et al. Kind of haunts me, because this is what genetic counselors and geneticists cite when they say that they have to continue following babies who have T112A homozygous or compound heterozygous genotype, because this is the only pediatric case that I think is out there, and it's questionable whether or not this baby or this child actually has Krabbe disease. We've talked about it in smaller expert groups, but I think it's important to put it out there that there were experts in this room that were asked about this case before it was published and said they did not think this child had Krabbe disease. The child had normal GALC enzyme activity, no cytosine. And if you look at the clinical presentation, it's quite unusual. And so when we have, respiratory issues, hypoventilation, skin hypopigmentation, fevers, it just doesn't quite fit even what we've seen in late infantile or juvenile cases of Krabbe disease. So there are a number of people who say that this case does not seem to reflect Krabbe disease. And if that's true, but if it's also what's encouraging people to continue following all of these babies, then we have some education that we have to do. Almost all of the other, actually all of the other articles or literature talks about adult onset cases, and they tend to have unique or different neurologic phenotypes. And so we have mostly middle-aged individuals that present with a variety of neurologic symptoms here. There are some older articles. So the one by Dr. Wenger at the bottom of this slide said that basically he did not think at the time that T112A or Y319C would cause disease in the homozygous state, but only if there was a pathogenic or more severe variant on the other allele, so only in compound heterozygous patients. And now we know that's not true because of this one New York State case where the homozygous Y319C and I562T and D248N infant presented just before 4 years of age. But we wonder if it's still true for T112A, the variant that we're talking about. And you'll see here T96A, that's legacy nomenclature, an old name for the T112A variant. And there are more examples of spinocerebellar ataxia presentations, which is interesting in these patients because we wonder, if this variant in the homozygous or compound heterozygous state doesn't cause what we think of as Krabbe disease, could it still be pathogenic for other disease types, other neurologic states? And finally, this is one of the newer articles that just came out last year that presented on an adult patient who was compound heterozygous for T112A and then the 30 kill-base deletion, which we know is the most severe one. And there was some question about this individual too. And although there's reduced GALC activity, which you can have in all patients who have a genotype that's concerning, there were some of the cellular studies that didn't really quite play out that this was Krabbe disease in this patient. So in summary, our clinical outcomes data has shown that there are multiple patients with clinically confirmed symptomatic Krabbe disease who have one of the first three variants that we discussed, the M117V, the L634S, and Y319C. And I think all of those will likely be called pathogenic moving forward. But thus far, we in our data set have not identified a confirmed case of Krabbe disease in a patient with a genotype that includes T112A. And that involves also our experience in the lab. We've tested multiple adults that have been found in carrier screening to be homozygous or compound heterozygous for T112A, have normal cytosine, reduced GALC activity, but are asymptomatic. So some other data that we have internally. So we'll continue to obtain some clinical outcomes from this, but I think it may be helpful. Future directions, we'll keep looking at the outcomes data of patients with these variants. We're working towards a complete variant annotation of GALC, and so we're working with Dr. Vanderver and Dr. Adang at CHOP, who submitted a ClinGen grant to push ahead the GALC variant interpretation and assessment of all of the different variants. So we might have then complete data and better information on these. And finally, we know that we have some great partners in the basic science labs who are creating mouse models. For example, Dr. Crocker just created a Y319C mouse model, presented data about 6 months ago, and those mice live a lot longer. And so the great thing there is there can be therapeutic trials that can be done on mice that have some of these later onset variants as well. And I want to thank everyone who's in this room or online who have partnered with us or may partner with us in the future. We really appreciate your willingness to collaborate and share data because that's how we all learn and make newborn screening better. Thank you.